Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Kirthana Pakanati.
Dr. Lala, Dr. Gulati, welcome to the Heart of Prevention.
We're so excited to be here with you.
Thanks for having us.
Thank you both so much for making the time. I'm really excited about today's episode. And before we jump right into heart failure and prevention, I'd like to tell everyone listening a little bit about the two of you for today. Dr. Anu Lala is a professor in the Department of Cardiology at the Icahn School of Medicine, Mount Sinai, an associate professor of population health science and policy, the director of heart failure research, program director of the Advanced Heart Failure and Transplant Fellowship, and co-editor-in-chief of the Journal of Cardiac Failure, which is the official journal of the Heart Failure Society of America. Dr. Martha Gulati is the director of the Davis Women's Heart Center, professor of cardiology, Davis Women's Heart Endowed Chair in the Department of Cardiology at Houston Methodist DeBakey Heart and Vascular Center, and the immediate past president of the American Society of Preventive Cardiology. And in case you couldn't tell from their wonderful titles, we're going to be talking about all things heart failure and prevention today. So I'm going to start us off by saying your recent HFSA ASPC scientific statement reframes how we look at heart failure as a preventable disease. Why do you believe that the field has historically under-prioritized prevention in heart failure? And we'll start with Dr. Gulati.
Well, thanks for asking that question. I think a lot has to do with our focus as a cardiology community. I think the biggest focus even when you get trained in cardiology is about ischemic heart disease. And we're always talking about plaque and not to underemphasize a very important disease, but we really haven't focused that much on heart failure. And in the meantime, we've watched heart failure become bigger and bigger and bigger. And part of that is because, some parts of heart failure develop as a result of ischemic heart disease, and we're getting better at treating ischemic heart disease, and people are living longer, but then they're living with consequences that ultimately lead to heart failure. But I think, we had older risk scores. And when you think about the early Framingham risk score, we did actually talk about heart failure risk and atherosclerotic cardiovascular disease risk. The problem is then when we moved to the pooled cohort equations, we started being just focused on ASCVD risk or atherosclerotic cardiovascular disease, and we sort of pushed heart failure out of the game. And I think it's surprising to me, just given, again, these diseases share so many risk factors. You can sometimes go down the pathway of heart failure and sometimes the pathway of ischemic heart disease, but we seem to deprioritize or even talk about the fact that we could prevent heart failure.
Absolutely. Dr. Lala?
I mean, as always, I completely agree with Martha. Martha has to be credited really with opening our eyes to this paradigm several years ago when we asked her. I think subliminally, we always knew this to be the case, but she helped us articulate it. We asked her to be an associate editor for the Journal of Cardiac Failure. And at that time, people were like, well, she's a prevention guru. Why are you doing that? And it made so much inherent sense to us, but she helped us really articulate why. And she said, I think this is so important because we are so focused on just reactive treatment and not proactive assessments of patients. And we really need to be thinking about heart failure prevention. And then slowly over time, we started to see the guidelines in 2022 published in JCF incorporate prevention in their top 10 takeaways. And really a lot of what she laid out, and others for that matter, but maybe not with so much attention, is really panning out. And it's so exciting to see that take place now. I think heart failure has long been framed as an end-stage diagnosis, right? It's like, that's what we react to when symptoms appear. And that mindset has basically completely pulled our focus to just really being fixated on downstream effects. But what we're recognizing now, and I think what this statement that we had the privilege of co-authoring together with other real luminaries on both sides of subspecialties, is that heart failure is the cumulative result of many risk factors. And now it fits more appropriately in this cardio-kidney metabolic health framework that unfolds over decades, right? So prevention requires us to act earlier across specialties, holistically. Also, I would say incorporating mental health and psychological well-being across the life course of a patient. So I'm extremely excited about that. I think our systems and culture are only beginning to catch up to that reality, and we have our work set out for us, but this is an important start.
Absolutely. And what a privilege, I mean, for our listeners to be talking to people who co-authored the paper. I mean, this is immediately shaping the future of, heart failure and prevention as we know it. And I wanted to take a moment for people to know that in their real world practice, the article outlines stages, right? From at-risk preclinical structural disease to symptomatic heart failure. And for someone who's in clinical practice and sitting there in clinic and thinking where to align their patients, would you be able to just walk through a little bit of what those stages look like? And we'll start with Dr. Lala.
Yeah, thanks, Kirtan. I think that's such an important question, right? How do we incorporate this into our clinical practice? Reality is, at risk looks like patients with obesity, with hypertension, with diabetes, with kidney disease, or especially in women, any history of an adverse pregnancy outcome, right? That's that stage A. Stage B, or preclinical disease, is where we start to see structural changes or biomarker signals, even if patients feel well. So they don't have symptoms and they never really had symptoms. And then stage C, or symptomatic heart failure, is the bulk of what we deal with on our end of things, where this is where we traditionally engage with patients, right? They're symptomatic, they have signs and symptoms of heart failure, they have structural and functional abnormalities. But the real opportunity is to intervene earlier, like we were talking about before remodeling becomes irreversible. Because most people think of heart failure only as that symptomatic heart failure where people are really short of breath, volume overloaded, or God forbid, stage D, which is where we're considering advanced therapies. And the reality is the spectrum is so much wider, and it's all of our responsibilities to be able to identify those patients. So I think, Martha, you have really laid so much of the groundwork in this space where prevention, and specifically, I would argue, women's heart health really intersect. And the reason I'm pointing to that is with Heart Month coming up, and we recently had the privilege of talking about women's heart health as it pertains to prevention of heart failure. So what are your thoughts?
Well, I think you articulated it so nicely. I mean, I think that entire spectrum, depending on what you do, you see these patients. Every one of us sees these patients, but at different stages. So, of course, when we see the later stages as a preventive cardiologist, I'm like, why are you in my office? Please go see Dr. Lala. But the reality is we are the ones that have the ability to see patients particularly in stage A and B, where we should be talking about this, where we should be telling them more than just having a risk of a heart attack, talking to them about these other disease processes that occur and that this is preventable. I mean, there's a lot of people that, think it's just inevitable if they have a family history of heart failure, well, that's just going to happen to them. But there's so much we can be doing. And so I think identifying them is key. And I think the traditional risk factors, of course, we think about. But I think, again, as Dr. Lala said, there's some things, even sex-specific risk factors, that we need to start thinking that this person may be at risk just by the presence of this disease that they've had. Maybe it's disappeared. For example, things that happen during pregnancy, some of the adverse pregnancy outcomes. I know we are now getting people to think about their atherosclerotic cardiovascular disease risk, but I don't think we're often thinking about heart failure when we see those risk factors. And so even diseases of inflammation that disproportionately affect women, but not exclusively. Again, are we thinking that the only thing about inflammation is that it causes ischemic heart disease, or are we able to recognize that link also with heart failure? And I mean, it doesn't matter if we communicate that with with our patients about why we're doing things necessarily, but it may matter if that person individually has a risk for, family history of heart failure, to be communicating why looking at these other risks, treating these risk factors is important.
Absolutely. Thank you so much for diving a little bit deeper into all of those at-risk categories that we see every day in clinic, and definitely getting a lot of the trainees like myself thinking about what we ask our patients every day when they come to see us. I do want to take a step back and ask, where do you see the biggest research gaps, and where do you think we really need to focus on understanding? I know you touched upon it, but really, where should we be looking to learn to prevent heart failure more effectively? And we'll start with Dr. Gulati.
Well, I think there's so many research gaps. I'll focus maybe a little bit on women specifically. I think that, the heart failure research has often left out women from their studies. More recently, we've seen those gaps close, which is really great. I mean, the newer community of heart failure physicians have actually been very intentional in their newer trials of targeting women and making sure that some of these newer drugs, newer studies actually include half women and half men, which has really been enlightening. But if you look at our older studies related to heart failure, women were just a very small portion of the population if they were included at all. And so I do think that, making sure that as we move forward with novel therapeutics, which is what makes heart failure, I think, very exciting in these last few years, that we are very intentional about including women. And I think one area that is lagged behind the others in terms of heart failure specifically is, in our understanding at least, is HFpEF. And I think HFpEF research, again, there's been a few newer trials and we're getting some therapies that for that population, but there's still a lot of work we need to do. And the one area that I would like to see more research in is related to this mix of INOCA and HFpEF, particularly microvascular disease and HFpEF. And I think we need more work in that area because I don't know which one comes first. I don't know if it's the same pathway. I don't know if there's unique treatments when they come together. What exactly are we supposed to do? And also, as a preventive cardiologist, how can we identify that phenotype in advance? And is there things that we can be doing beyond just blood pressure control and the traditional risk factor management? I don't know that we know that fully, but I would love to see more work from the preventive aspects.
Thank you so much, Dr. Lala.
I love this question. I think I want to stay optimistic. I completely, as usual, agree with Martha. I think we're making strides. I wish we're also learning a lot about biomarkers that can help us identify risk earlier on. I think for me, the biggest change in my practice has been the regular assessment of UACR and looking for microalbuminuria. I think we're refining our ability to understand lipid panels with greater detail and scrutiny and, moving towards personalized medicine in that regard. I think natriuretic peptides continue to be incredibly informative, even at earlier stages, even in that pre-heart failure category. So I think there's more to be done. I would like to see risk scores, just like Martha said, be more representative of broad populations. I think we're making strides there too. But it's never going to be this kind of plug-in medicine that we all secretly, just want. I think there's always going to be an art to that medicine. I'm really excited about some of the larger clinical trials that are focused on incident heart failure as a primary endpoint. That, I think, is a game changer. Martha and I have the pleasure of being a part of one of these trials. It's called Prevent HF. So it's very apropos name there. But it's a randomized a placebo-controlled phase 3 prevention trial of baxdrostat, which is an aldosterone synthase inhibitor, and dapagliflozin, which is an SGLT2 inhibitor, versus dapagliflozin alone. And the primary purpose is reducing incident heart failure and cardiovascular death. And so these are people, and this is over 11,000 patients that are going to be included. So as is typical of prevention trials, we need a lot of people because it takes a lot of time to get to these endpoints. But they're going to be followed until a specific, number, I don't remember offhand, of heart failure events and CV deaths occur. I think it's really, really exciting to see these kinds of trials underway where, yes, the lift is big and the time that we'll have to wait may be long, but thank goodness we're moving in this direction because it's shifting. Ultimately, clinical trials do shift practice and it shifts culture as well, and we're hoping that this scientific statement, in addition to others that were published in the Lancet, as well as a recent, I think, state-of-the-art review in JACC as well, there's this increasing recognition that this is where we need to be thinking because, and we haven't hit on this point yet, Kirtana, is that we have had incredible advancements in terms of discovery in heart failure therapeutics. And yet, we're not moving the marker as much as we would have thought with respect to mortality. Now, is that all due to the fact that we're diagnosing more people with heart failure? Is it that people are living longer and therefore there's more of a likelihood or time to develop heart failure? Yeah, maybe in part, but it doesn't seem like it's enough to explain the trends that we're seeing. And so this is what really begets and underlies the importance of trying to influence the prevention, to offset the incidence of heart failure in and of itself.
No, absolutely. Thank you so much for bringing up the point that while we've had all those advances, we haven't seen the marker move in the direction we want. And I know that you and Dr. Gulati really just touched on a few things, but I'm sure there's lots of things that you could say about where we want the research to go. I'm sure that's a whole episode in and of itself, quite honestly. I know that we're just going to be getting to really just an intro for people that are listening out there, but lots of things to talk about on other episodes, in particular with unique patient populations. I wanted to mention, the article does address social determinants of health, right? And I think that's so important. And I wanted to talk about how you find that, structural inequities really contribute to heart failure risk and outcomes. And also in the optimistic world of what public health or policy level interventions would you love to see that you really think would make a difference in preventing heart failure in vulnerable populations across the spectrum and in a multitude of different ways? So definitely a broad question with a lot to discuss, but I think it's an important one. And we'll start with Dr. Lala.
Yeah, I think, Kirtana, you're spot on. What an important question, right? Structural inequities influence access to things like healthy food, safe spaces for activity, right? Martha walks to work even though it's freezing in Houston right now. But we need those safe spaces for us to be able to do that. They also inequities influence cardiometabolic therapies, access, all these things long before heart failure is even diagnosed. So policy level investments need to occur at the level of healthy food. I mean, there's been a ton of, discourse around the recent food pyramid changes, and that's probably an episode in and of itself. But healthy food, what's exciting is you'll see in ACC, for example, and we're seeing this more and more, there are an increasing number of clinical trials looking at really food is medicine. We say this, but are we testing it? And how do we increase that access? And what does that look like? So I think seeing more of these trials is really exciting, encouraging, and ultimately will have to translate into policy level investments. We are seeing it to some extent, although it needs to be evidence-based and backed. I'd say food would be my number one, followed by safe spaces for activity. I mean, how often is it that you're able to walk to work safely? How often is it that you're able to walk from one place to another safely? Can we create greener environments so that that is celebrated and that is more of a cultural norm? Even if it means like on days like today where we're snowed in, underground avenues for walking, but really kind of encouraging that cultural shift. I think that can meaningfully reduce heart failure risk, especially in populations that may be more vulnerable. Martha, what would you say? I think this is an area where prevention and equity are inseparable.
Absolutely. And obviously, where you live always will matter, right? Even in terms of environmental exposures, if we think about the changing environment on this cold day, we can't help but think that climate change is real, but exposures to different things in America, particularly your zip code, means a lot in terms of your own personal exposures to things you that can affect your health and particularly can affect your heart. And so I think thinking more about that, and again, from a policy aspect, I think that's where, when we think of what, as cardiologists, why we need to be potentially in the political space or at least advocating to our leaders about things, why we need to address conditions and access to healthcare, et cetera, for all our patients, it's because all of these things do matter. I think when we think about healthcare, even how prevention will be delivered, because,
Mm.
idealistically, as a preventive cardiologist, I want to prevent every cardiovascular disease in my patients. But the reality is these social inequities determine who I can be more effective with versus others who have access, first of all, to a preventive cardiologist, who has access to some of the medical therapies, especially the novel medical therapies we have right now, who gets them. Often it's the people that are better insured with better coverage, and the people with less good insurance often they're not always entitled to novel medications, and let alone this must be even accentuated further when Dr. Lala is treating people with advanced heart failure. I can't even imagine telling, we walk around saying everyone with heart failure needs to be on SGLT2 inhibitor, and if you can't get on that, if you don't have access to that, then what happens? And that I think is always, a concern for all of our patients when we write the therapies, who can get the therapies. And then from the beginning, can they even get to us? Can they get even to the basic healthcare provider, their primary care physician? Because that in the US is increasingly a problem, that there isn't enough primary care providers. And again, as there's shifts happening in that type of healthcare into concierge medicine, well, again, the people that can afford it are going to always be the healthier population.
Yeah, absolutely. Thank you for drawing our attention to a lot of those important topics. I wanted to just shift a little bit here, and I thought we would do a little rapid fire, especially since Dr. Gulati and Dr. Lala are such good friends. We'll see if their answers are going to be exactly the same for a lot of
Woo!
these. But I thought we'd start off, and feel free to just say your answer. The first one that I have is the biggest myth about heart failure that you wish would just disappear.
Ooh. Do I go first on this one?
You go
Sure.
first.
All right. I would say that it's an endpoint that is irreversible for patients.
And I would say the biggest myth about heart failure is that it means failure, like that there's not something we
Yeah.
can do to improve cardiovascular health long term. I think that, Anu and I talk about this all the time. That name is terrible, and it really, to our patients, often you underappreciate the impact of getting a diagnosis with that name.
100%. We're pro heart function.
Yes.
I definitely have heard you both say that before and have changed how I approach that in clinic with my patients. And it really does make such a big difference. It makes a much more positive environment. What is your favorite quick way to explain the heart failure continuum to patients?
Ooh, I think heart failure doesn't start with symptoms. It starts years earlier with risk. And risk is what we can act on. And so I think starting from a space where we're promoting health rather than reacting to disease is, I think, an effective way to talk to patients about it.
And I think the way that I talk to patients, I don't necessarily, I admittedly don't talk necessarily about the word heart failure in my discussion, but identifying somebody with a lot of risks for heart failure and other diseases, I talk about preventing cardiovascular disease and any type of heart problem. This is where it starts. So let's work on reducing your risk factors here, because the earlier we can control this, the more likely your heart stays healthy for your entire life.
Absolutely. So we don't even get to the heart failure part. We start with the stuff before that. Yeah, that makes a lot of sense. What's one innovation in cardiology as it relates to prevention or heart failure that really just makes you excited for the next decade?
Well, I'm super excited. I think these cardio kidney metabolic therapies have really begun to revolutionize not only outcomes for our patients, but what I really enjoy about this, cultural shift that we're experiencing is that it's showing us how every system is connected, how we can't continue to operate in silos of expertise, how the kidney affects heart risk and vice versa, and liver for that matter, with, MASL D as an example. I think these therapies are not only instrumental for treatment once heart failure has developed, but it's also instrumental for the prevention of heart failure. So, what we haven't talked about thus far is I, prevention is applicable no matter what stage of life slash disease slash health you are in, whether it's before the onset of heart failure, whether it's during heart failure and you're practicing secondary prevention, and it's even applicable to those people who have had a heart transplant or an LVAD. The things that we're managing are cardio-kidney metabolic risk or comorbid conditions in those stages. So I'm super excited about really this cultural shift that is alongside really groundbreaking science.
And I'm totally in agreement of that. I think if I can say what I'm most excited about that may change how we identify people at risk, I think increasingly we're all talking about AI and how it might help us. But
Mm,
here's one place that AI may be able to, scour our records or see the life course of an individual and identify a phenotype of patients that we should be focusing on, particularly related to prevention, finding the people that are at the highest risk and being able to use that technology somehow to be able to gather those people and tell people, here is your risk. You know, I think that's one area that I'm excited by. I think another area that, as a preventive cardiologist, is gene editing, particularly when
mm,
we know a genetic abnormality exists and we want to correct it. And I know we've heard a lot from the company Verve as one of the many companies out there doing this work, and I know it's heavily related to lipids, but their technology actually is transferable to other genetic diseases. And so for the diseases that are genetic that in the past we've not been able to do too much, just manage, that I think is an exciting area. I mean, we're at the infancy of understanding it. There's a lot of ethical considerations. There's, of course, we need good outcome data, but I do think it makes us all very excited because it's something I think most of us just dreamed of, and amazingly, we're getting closer and closer to potentially having solutions for genetic abnormalities.
Yeah, thank you so much. I do want to ask because for everyone that's listening, these are two clinicians who definitely talk the talk and walk the walk. As we know, you both are very on top of your own health. And so, just for everyone that's listening, a non clinical question for you both. What would you say is your favorite heart healthy snack or go to stress relief activity?
Heart healthy
ooh.
snack, I'll say edamame. I love edamame. I think I ate it last night as my dinner, to be honest with you. Um, and then my heart health activity is, everyone probably knows I don't own a car. It's my contribution to the environment is to not have a car. But that means also I walk to work. So I think that is like the way I start my day and the way I end my day, walking 2.5 miles home and 2.5 miles to work. And it's actually the best part of my day. So I highly encourage people to think about how they can put more steps into their day. It's the easiest way to make it happen. I do lift weights as well because I in the last maybe probably 4 years is when I picked that habit up. I used to just do aerobic activity and thought running was enough. And I think it's transformed my life in a really weird way. But people that know I post it quite often on my social media, it's only to motivate me. It's not for anyone else. I'm sure everyone's like, she's insane and why is she doing this? But the fact that I actually went from somebody who never lifted weights, I would tell other people to do it and not do it myself. And now I have been brainwashed and I feel like I'm living evidence for the benefits. So
Well, I don't think anyone quite walks the walk literally and figuratively as Martha does. But I'll say my heart healthy snack is I absolutely love avocado. So like a snack for me is like I'd love to slice an avocado, put a little lemon, a little salt on it, and not too much salt, but enough that it's tasty. That's like my favorite thing. And then really what I do enjoy most, and I can't say I do it every day, is we happen to live close to the Hudson River. I love going for a long walk without a phone. I think that's the key difference, for me. I feeling like just that half an hour of being detached. I generally, if I'm lucky, I get to do it with my husband, so we get to catch up as well. And it's just a brisk, long walk, and it feels like you sort of shed the challenges slash just ups and downs of the day. I'd say that's my favorite thing. The other thing I would say that I'm really enjoying and working on making more of a regular habit is just I started doing what's called Sudarshan Kriya breathing. So it's called Sky, and it's a very effective breathing practice to kind of just regulate your sympathetic and parasympathetic nervous system and your mind to get a little clear.
so cool.
Amazing. Well, I know we just barely scraped the surface of all things heart failure. What an incredible introduction with two, visionaries in the field, literally writing the guidelines. And it was such a privilege for me to get to chat with both of you. Thank you so much for taking the time. And I'm really excited for further discussion and conversations about all the other topics that we brought up during our discussion today.
Thanks
Well,
so much,
thanks,
Kirtana. I
Kirtana.
hope you'll have us back.
Yeah, thank you so much. Absolutely, in a heartbeat.
But
Oh, yeah.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.